Good afternoon, everybody. I'm Christy Koenig, and I serve as the EMS Medical Director for the County of San Diego, and we welcome you to our evidence-based medicine presentation as part of the Base Station Physicians Committee. This month, we are very pleased to CARES, the Cardiac Arrest Registry to Enhance Survival. The title of the talk is Who Cares? We Do. And we're very pleased to welcome two speakers for this talk. The first one is our very own Dr. Brad Schwartz, who has expertise in medical contact centers, including nurse advice and triage and virtual medicine, serves as the medical director for the San Diego Regional Cooperative Care Partnership, or RCCP, and also for AMR San Diego. He brings over 30 years of experience and is very passionate about this topic. The second speaker, we're very thrilled to invite Dr. Angelo Salvucci, who's the former medical director and current assistant medical director for Santa Barbara and Ventura County EMS. He has served as chair of the State of California EMS Commission and president of the EMS Medical Directors Association of California, authored numerous presentations, and as medical director for EMS, he started a cardiac arrest management program which has substantially improved survival in patients with out-of-hospital cardiac arrest. So thank you both, and we're really looking forward to your talk. Over to you, Brad.
All right, let me see if I can share my screen here and do a better job than I did last time, getting it all there. Can you see my screen?
Yes.
Yes.
All right. All right, well, I'm going to just quickly review a little bit of the highlights of what we went over last time, and then Angelo is going to continue with some more details and support or refute some of my ideas and our ideas, and hopefully at the end we will have a better feel for where we stand with cardiac arrest and our CARES data, and also maybe some ideas of what we can do for improvements going forward. So if you remember, we have this many arrests in San Diego in 2021. There were 2,219 cases. Overall survival rate was 9.2%. That means we saved 204 lives. And I put out there that, with other counties, very few of them, but some other counties that have reached 20% survival rates and some slightly higher, that we could save a couple hundred more patients if we optimize all aspects of treating cardiac arrest. This was just a graph to show you where we started. I think you remember that slide I had about Jim Dunford's presentation, where we were at 4% in the late 20,000, around 2000, I guess. And then you can see where we progressed since then. The various agencies, AMR implemented in 2012 some improvement in the steps of cardiac arrest and making sure we were providing quality care. San Diego City did the same thing in 2009 and improved their numbers. But simultaneously with us, both of our agencies improving the quality of the CPR or cardiac arrest care that the pre-hospital gave, you can see at the bottom there was also a concomitant rise in the percentage of people who were getting bystander CPR, which we know is also key. So probably the combination of the two is what resulted in our improvements and bringing us up and sometimes surpassing the national levels. Now, remember last time I was mentioning that I was curious as to what percentage of bystander CPR is true bystander CPR, in other words, started immediately by somebody who knows CPR, perhaps, versus dispatch, where it's delayed and somebody may not be as facile at doing CPR. And I was able, Angelo gave me a contact, which was Mika Panchik, I think you say his name, his references there at the bottom. And he gave me couple studies which showed that in these studies, about 43 to 45% of CPRs are dispatched related CPR, which is what I was guesstimating was occurring in San Diego. So we're probably very similar. Now the question becomes, does that affect the survival? Is one better than the other? And the data shows that they're about the same. So it appears that maybe the improved count that you get with dispatch counteracts the delay you have in giving it. Needs to go up on mute, I think, or somebody's asking a question. Not sure. So that's interesting. So both work, but we still have to maybe have an overall total rate that's higher than what our current rate is, which is around, close to 50%, maybe 45%. So remember our numbers. Our mean age is the same as everybody else, so there's no reason that our survival rate should be lower because of older people. The relative percentages of where these occur is pretty much the same. So again, probably isn't the reason for our not being, higher, or, why we're equal to national at this point. Our bystander CPR rate is actually a little higher than others. The other data that was important was, the bystander CPR rate, to note, in Seattle is 70% plus. So that maybe explained why they have a 20% overall survival rate and we're at between 9 and 10. The number of asystole versus VFib or shockable rhythms is not too different, and our overall survival rate right there at the bottom, 9.2%, 7.8% with moderate to good cerebral perfusion or performance. And you can see where we compare to national and California. So we're doing okay when compared to national and California. But remember, there are a lot of, and Angelo may touch on this, there are a lot of agencies in CARES now. And, of note, most importantly, that there is a potential to get to a 20% survival rate. And that, I purport, should be our goal. When you look at our distribution amongst our agencies, you see a great disparity between the highest and lowest survival rates, 15.3 versus 4.5. Age difference isn't too huge. Bystander CPR rates are a little different in the highest versus the lowest. And you can see the nursing home and public, slightly different in the lowest, where it's mostly in more home than public. And you can see the shockable rhythm rates and AED. So again, the highest area has high AED rates, high bystander CPR rates, higher public occurrence. All these things we're well aware of. It makes sense. So the suggestions going forward is to increase community CPR. You've heard me talk about how we can do little classes here and there, which are good, but we really need some huge social media or public service announcement or huge event, Padres event, something like that. The schools provide CPR instructions. I don't know if they're required to do that in some areas, but I don't know how enforced that is. We can increase our AED availability, although we are a pretty good community with regards to this. And then we should always continue to reinforce and oversee our pre-hospital care personnel with regards to their performance of quality CPR, which seems to be good, but we need to be careful that it doesn't deteriorate. And as we use auto pulses and Lucas devices, we have seen in some areas when that's first initiated that because of the delays that those can incur, if you don't organize how to put it on quickly, that can cause a decrease in our survival rate. So we need to be careful there. So that's all I have, and I'll turn it over to Angelo.
Okay, well, let me thank you, Brad, and thank you, Christy. Is it simply screen share? So I may hear technophobic, but I'm really not. Let's see, share screen. It says this will stop, yes.
There you go.
And how, let me just see if it works. All right, is that showing us full screen now?
Yes.
Perfect.
Okay, so this is what I want to talk about and what Christy asked, and I hope this meets your guys' needs. I want to talk about CARES, but mostly about how CARES can transition, or communities can transition the registry aspect of CARES to the enhanced survival, which has always been the goal, but not commonly achieved. That's my clever little copyright. It's not copyrighted, but it'll be our little secret that that this is my idea. No disclosures. So I think we all know that cardiac arrest survival as a nationwide effort has not really undergone the transformation that we had hoped. In fact, in the nearly 30 years between 1980 and 2008, it hasn't changed at all. And that's not to say that some systems haven't done quite well. In fact, if you simply increase, well, not simply, but if you increase the survival in the lowest performing systems to that just of the median, not even to the highest, that would prevent 15,000 deaths a year. This is a much more recent article by McNally and his group, and this was published about 3 weeks ago, and really showed the same general concept, which is there's a broad spectrum of performance amongst individual agencies. Previously, we were looking at states and regions. This is looking at individual EMS agencies. And the overall survival has quite a broad range, as you can see in the graph on the lower right. Their conclusion, and I'm not sure exactly how helpful this is, but shorter response times would improve outcomes. I think we all understand that. And adherence to evidence-based termination of resuscitation protocols was also associated with lower likelihood of survival, or non-adherence. So this is where I think we all stand before we start looking at CARES. It's human nature and the nature of EMS systems certainly to take the approach that we live in a place where the women are strong, the men are good looking, and all the children are above average. And if you talk to any EMS system who hasn't looked at their cardiac arrest outcomes, they believe they're doing great. And we were, in fact, one of them in Santa Barbara and Ventura. So CARES now monitors and has reporting 51% of the population of the United States. It's increasing by leaps and bounds, and will hopefully be 70, 80% in the next few years. But way back in 2008, we were fortunate enough in Ventura County, and then 2 years later, Santa Barbara County, to be one of the early participants in the CARES system. This is a 2008 map, and you'll see Ventura alone in the west. So I'm going to jump to Santa Barbara, and the Santa Barbara and Ventura systems overlapped, and I just think this is the best way to tell the story. We started in Ventura, but 2 years later we started in Santa Barbara and had a very similar result. We were very disappointed to learn that our cardiac etiology, our overall cardiac arrest survival rate was 8%, the national average was 10.3, and our Utstein, our bystander witnessed shockable rhythm, was 25%, and the national average was 32%. And we faced what I think many communities are facing right now. which is we know what needs to be done, right? You have a more robust community response with lots of AEDs, good CPR training, dispatcher, telecommunicator directed CPR, on-scene responders, rapidly assess, rapidly respond, and rapidly assess. We perform high quality chest compressions, continuously manage the airway, ventilate not too fast, defibrillate, give medications and fluids as needed, identify ROSC, provide good post-ROSC care and transport, preferably to a place that can perform PCI and targeted temperature management. And we did all that in Santa Barbara for a year. And what we found is we were really just doing a bunch of advanced intensive wheel spinning. Our performance didn't improve. We spent a lot of time, a lot of effort. We were sure we were getting better, but we were really doing the same thing more intensively and didn't improve at all. We rolled our sleeves up and started examining what we had already started in Ventura and created from that Ventura experience and from the literature a new way of approaching the cardiac patient. And our idea was that with that, by looking at education, training, treatment protocols, and quality improvement, we could do better. This is what we did. The numbers aren't as important as the general concepts, which is to have evidence-based treatment protocols. Everyone is involved. We believe that the education should be minimized and that the training should be maximized. And it's followed up with a robust QI program. These are some of the actual slides of the training program. We all understood and agreed that we were going, our goal was to maximize the number of cardiac arrest patients, not who left the hospital, certainly not who just arrived at the hospital, not who were admitted, even though those are in many systems the goal, or even went home, but went home with good or moderate outcome, cerebral outcomes, cerebral performance scores, which are CPCs 1s and 2s. So went home with a CPC 1 or a CPC 2. This was our overall philosophy, that assessment, positioning, rapid, continuous, high quality CPR and defibrillation were the cornerstones, and less important was endotracheal intubation, access, vascular access, and pressors. We're very systematized in where everyone is and what everyone does. Everyone's got a job, everyone does their job, and there are people who make sure you're doing your job. And there's a constant feedback loop. Again, the numbers are not important as setting a standard and holding everyone to it, making it part of training and making it part of the QI system. And they understood why they were doing it. Gives them a better chance of defibrillating and better chance of the patient waking up and walking out of the hospital. Airway was, again, we emphasized BLS and de-emphasized endotracheal intubation, although certainly it's an option if the airway can't be managed otherwise. And we engineered in a way not to hyperventilate. This actually was the first and greatest improvement in Ventura County's early experience in 2008, where we were approached by this company to begin training. And you can see in kind of upper left the bars, and this is the Ambu SmartMan, and it is a way of measuring each compression. And you get a different colored bar, and it's measured at the conclusion of each compression. So within just a few minutes, you're doing all compressions of adequate depth, rate, and recoil. And training on this every 3 to 6 months has really improved the adequacy of CPR. And this is how we can at least show the continuousness of the CPR, and we can see pauses, duration, rate, and then the CPR density. But this does not show us depth, so we're relying on training to assume the depth is appropriate. So this is what happened after that CAM training program. So from 2012 to 2013, we saw a more than doubling of our overall survival, and about the same for our Epstein, our shockable bystander witnessed shockable first rhythm patients. It was a sustained improvement. This was the 2 years before and 4 years after. So again, roughly double survival for overall, and about the same for our shockable, bystander witness shockable. So I mentioned before that we learned some of this from the Ventura. So you'll see that we started a couple years earlier in Ventura, and the improvement between 2008 and 2009 and 10 was solely because of the CPR training. We paused it a little because we were attempting to continue to improve by using the King airway as a circulation adjunct. That ended up not improving, in fact, reducing the number of CPC 1s and 2s. We abandoned that, and then you'll see once we introduced CAM, even in a high-performing system, introducing CAM resulted in a significant increase in survival, overall survival, and the Epstein cases. This one actually went on for the next few years. I retired in 2016, and under Dr. Shepard's direction, it actually increased and stayed in the mid 50% range before COVID. And the final presentation I've given before today was a couple of years ago at the European Resuscitation Council. And we looked at, I think, as I've mentioned right at the very beginning, what I think we should be looking at, which is the likelihood that you're going to survive your cardiac arrest and walk out of the hospital. And for those of you who haven't seen the IOM, the 2015 Institute of Medicine report on cardiac arrest, it's worth looking at. They've taken this model from disaster preparedness, disaster response, starts with comprehensive surveillance and involves public and EMS and hospitals and research and continuous quality improvement with the goal of improving patient outcomes. What we did in this report was look at how our CAM system, which was developed before this report, matched up with the goals of the report. And in fact, they matched up pretty much line by line. So I would agree, they would agree with us, and we would agree with them that the model they look at it pretty much matches up with what CAM is. And here's the results. And again, I would argue to you, even though you're not going to find this published much in the literature, it is a line in CARES, which is your neurologically intact overall survival or cardiac etiology survival, CPC 1s and 2s. And that's the national average through 2018, and it's not changed, actually gone down a little nationally. And that's the Santa Barbara one, which is 40 to 50% higher, and that has continued. But one really important part of CAM, and you all know this from your hospital systems of care, that you need to be constantly watching it, because as opposed to the Ronco rotisserie, really systems are more like this. If you don't constantly apply that pressure, then they become disorganized. And the pressure is in the form of surveillance, measurement, quality improvement, discussion, presentation, and that's how you're going to sustain those gains. So for those of you who thought this was too long and didn't read or didn't listen, this is the quick summary. I believe any system can improve their out-of-hospital cardiac arrest survival. That CARES is not the end, and too many systems, and in fact, one in California recently did this, was part of CARES, looked at it very carefully, reviewed their numbers every year, and when they didn't go up, have actually withdrawn from CARES. Not sure what the expectation was, where the expectation came from that the numbers would improve magically, but the numbers are only information, they're not the answer. Yet you really need to engage the entire system and then build interests. The success feeds on itself. Your providers want to do better, and when they hear that more patients are going home, walking out of the hospital, they become very excited, and they want to do exactly what the protocols say. The costs are modest. Training in CPR was the mannequins was our biggest cost, and that's several per agency. We don't use, I think you'll notice I did not mention use of Lucas. We don't use Lucas, or we didn't. Part of Ventura uses Lucas now. We've not seen any improvement. I don't believe, personal opinion, I don't believe that automated CPR devices are better than optimized CPR. That comparison, to my knowledge, is not in the literature. Optimized CPR, when you look at Lucas publications, is doing the same training again, but doing the training with a feedback mannequin really does get people to do CPR well, and maintaining the oversight, fighting that second law of thermodynamics. And that's one of the happy results. That's me in the center, surrounded by a bunch of cardiac arrest survivors. The tall guy was an EMT who survived his cardiac arrest and now got married, has 2 kids. And the nurse on the left organizes a support group. These people are attending a monthly support group, and she still does it now virtually. And if you haven't done this yet, you'll be surprised, and perhaps not surprised, but it is gratifying to meet the ongoing needs of these patients who died. And there's a lot for them to sort through, and being in a group of people who had similar experiences is really helpful. All right. Well, when I put it on full screen, I couldn't see the time, so I hope I didn't go too long, and ready if there's time for questions.